Hello, everyone. Welcome. We're going to give everyone a chance to get logged in, and then we'll get started. Thank you for joining us on a Friday evening. I am so excited to have you join us. My name is Marie Boone Clark, and I am one of the founders and executive director of Birthing the Magic Collaborative. We are a nonprofit that curates virtual medical education, so our perinatal education for Black birthing people. And I am too excited to get to the person that's with me tonight. I have stalked her a teeny tiny bit, and so a little bit of a crush. So I want to allow Dr. Yukachi to introduce herself, and then we're going to dive in and talk about a subject that is near and dear to my heart, because I think if we could better understand it, we would make a dramatic change in how a lot of our mamas experience their pregnancies. So Dr. Yukachi?
Hi, good evening or good afternoon for those of us who are here in different parts of the world. I'm over here on the West Coast. My name is Yukachi Emerowa. I am a Nigerian American, born and raised in Southern California, where I currently practice out here at UC San Diego. I am a maternal fetal medicine subspecialist. So for those of you who don't know, this means I specialize in taking care of high-risk pregnancies, which can be high risk for a number of reasons. So trained more generally as an OBGYN. So that's my original specialty. I am a clinician, I am a researcher, I am a Black woman, and all those things bring me to my interest in hypertensive disorders of pregnancy, which some of you may more commonly know as preeclampsia. So I spend a number of my time caring for people who are at risk for or go through that condition, as well as doing research to improve outcomes and diagnosis related to preeclampsia. So I'm ecstatic to be here. Marie, you always make me blush. You introduce me or talk to me. So I'm glad to be here.
Oh, what's the old saying? Those who can't do stalk those who can, or something?
Something like that.
I made it up, and then to do it so well dressed, it's like,
I try. It's the one thing I got to keep together, even when everything else feels like it's falling apart sometimes.
You add the additional layer. Well, for those who are joining us, if you have questions, I think we're going to keep this very informal. There are no slides. So drop your questions in the chat. And also, we'd love to know where you're joining us from. Is it in the middle of the afternoon like it is for us? I'm in Scottsdale, and or is it evening and you're sitting back with a cocktail? Let us know that as well. But I think the first question, we'll just dive right in for those who are joining us and really have a curiosity. What is preeclampsia?
Yeah, so preeclampsia, I think those who have heard of it most commonly know of it as high blood pressure in pregnancy. So I always like to start to try to orient people to what they may have heard and then make sure we're all on the same page when we talk about it. So it is often most commonly diagnosed or picked up with high blood pressure in pregnancy, but there's kind of more to it than that. So I try to back up and make sure that people I'm taking care of are on the same page as their clinicians when we talk about preeclampsia. Preeclampsia is essentially a condition that's caused by the placenta, hence why anybody with a placenta can get it, where the placenta, for no fault of anybody's own, kind of malfunctions, sets up shop incorrectly, and causes a lot of inflammation in the body. That inflammation can result in what we commonly see as high blood pressure. So even if you had no high blood pressure before pregnancy, it can happen to you because it affects the blood vessels. It can also affect your kidneys, cause kidney damage. It can affect your liver, cause liver dysfunction. It can affect the brain, lead to seizures, which some people may have heard of as eclampsia. And it can affect the placenta and thereby affect the baby and the baby's growth. So you may hear your doctor, your provider, your midwife talk of it as a hypertensive disorder of pregnancy because there are variations in how we describe preeclampsia, most of which center around some degree of high blood pressure. So if you hear gestational hypertension, preeclampsia, superimposed preeclampsia, HELP, all those kind of come in the same spectrum of disorders that are caused by this malfunctioning placenta.
Wow. See, I did not realize there were so many different, would the right word be categories?
I think, we can say categories, conditions. Yeah, they're kind of their own sort, I shouldn't say independent conditions, yeah, but variation of these conditions or categories.
So, Dr. Yu, and forgive me if I could, when is there a point when one develops preeclampsia?
That's a great question. That is a great question. So, and that's part of the reason I like to start with an understanding of kind of what's underlying the disorder, because then everything else someone describes to you, explains to you, you're not just taking their word, it makes sense. That's why it happens that way, right? So we typically think of preeclampsia or hypertensive disorders of pregnancy, gestational hypertension, happening at 20 weeks on. Now, nothing in medicine and in health in our bodies is cut and dry, right? So I've certainly seen some cases of what seems like very severe HELP or preeclampsia that happen just before 20 weeks, but most of them won't happen until after 20 weeks. The reason being, before that, the placenta is this teeny tiny little structure and doesn't have much set up in the way of how it connects mom and baby to a significant degree. But by the time you hit 20 weeks, not only do you have enough body of that placenta, but ongoing connections between the person carrying the pregnancy and the baby. And so typically we diagnose preeclampsia after 20 weeks. Now, it doesn't mean you can't have high blood pressure before 20 weeks, even if you don't have it when you're not pregnant. But if you have high blood pressure before 20 weeks, which can happen, we tend to think of it as what we call chronic hypertension or essential hypertension, which are just definitions for high blood pressure that's not caused by the pregnancy. So the short answer is after 20 weeks, and I'm sure we'll talk about this more, extending through postpartum or after delivery, or when we can diagnose or call something preeclampsia.
So 20 weeks is when it tends to present itself. Yep. Generally, as the placenta is growing, what are risk factors first? Let's talk about that. Are there things that put me at risk?
Yeah. And I, sometimes I hesitate to say it this way because there's, a fine balance between awareness and fear, right? And awareness is like, knowing where we stand so we know what to look out for. Fear is when that information causes us to be consumed with, all these negative emotions. So I don't say this to cause fear, but I think it is really important for people to recognize. A friend of mine, Eleni Segas, who's the CEO of the Preeclampsia Foundation, they do great work. She often says anybody with a placenta is at risk for preeclampsia, which is very true, right? So that's why everybody at your doctor's visits, at your midwife visits, they check your blood pressure because it can truly happen to anyone. But of course, there are conditions or things that put you at higher risk for developing preeclampsia. And our kind of guidelines, the American College of Obstetricians and Gynecologists sets out very clear risk factors. There are probably more than what we capture. We're not great at capturing it, but we know that certain medical conditions can put you at higher risk. So I mentioned chronic hypertension, or if you have high blood pressure prior to pregnancy, certainly presumably higher risk that any placenta malfunctioning could cause that to skyrocket. Anything that affects the blood vessels or the underlying organs that become affected by preeclampsia. So in addition to high blood pressure, diabetes can also do that, whether it's type 1 or type 2 diabetes. Lupus, which can certainly affect your kidneys and your blood vessels. And then things that generally create more placenta for people to have. So twins or triplets, you have more placenta, more ways for it to go wrong. Those increase. And those are the categories of what we call the higher risk factors. There are some more moderate risks, which it increases your risk a little bit, enough so that if you have a couple of them, you're probably in that higher risk category. And so when you think of those, you think of what if it's your first baby? That's basically, as Wendy says, guilty until proven innocent. So first baby, you're at risk for preeclampsia. Extremes of age, and when I say extremes, trust me, I'm in my 30s. I haven't had my first baby yet, so not to kind of stigmatize having babies at older ages, but over 35, very, very young, probably those are also at higher risk of preeclampsia. Then there are some things that aren't explained biologically, but are probably explained by when you think of the social stressors around us. That stress translates to stress to our organs, to our bodies. So the reason I mention that is because being a Black woman, African American, is associated with higher risk of preeclampsia. It's not a genetic thing, right? Your race doesn't define your blood vessels, or certain socioeconomic stressors. And then if you've had poor pregnancy outcomes in the past, like if you've had a history of preeclampsia, that's actually a high risk factor. Or if you've had an early fetal loss, that might be one of those conditions. So there are a couple other things that we test for in the medical field that might put you at higher risk. But yeah, there's a couple high risk categories where the question I always ask myself when I meet someone is, what reason do I have to believe this person's not at risk? Because many people often are at risk.
So there is a question in terms of blood vessels. There's a question in the chat. Is preeclampsia associated with constriction of blood supply to various organs?
Great question. Not per se. I mean, you're right. I mentioned how it's release of proteins and factors from the placenta that affect the blood vessels. It's not so much that it constricts the supply, but more so that it causes damage to the blood vessels. So these kind of factors and proteins are kind of, I guess people say, like a rotor-leader through the blood vessels. Like it disrupts the lining of the blood vessels. It actually causes a lot of leaking, which is why you may hear a lot about protein in the urine. Those blood vessels that go through the kidneys leak, and so they leak out your protein. So it's more so leaky, damaged blood vessels than constriction. Now, with very severe medical conditions like high blood pressure outside of pregnancy or diabetes, where your blood vessels for other reasons might be constricted, that compounds the effects of preeclampsia, and you can see that in the placenta, but it's more so leaky, damaged blood vessels than constricted blood supply.
Interesting. Backing up a step, can you have a history of high blood pressure and not develop preeclampsia? Preeclampsia?
Yeah, you certainly can. Like I said, nothing in medicine is 100%, nothing is cut and dry. So, if you have high blood pressure outside of pregnancy, the bottom line is always optimize your body and your health as best as you can. So if you have high blood pressure outside of pregnancy and your blood pressure is really well controlled, to the point where your kidneys haven't really been affected, your heart hasn't really been affected, you're not having your blood pressure shoot up every so often, that certainly sets you up for better outcomes. And then some of it is just luck, right? Like I said, it takes kind of like two hits. One, you have a little bit of that baseline risk, and two, your placenta malfunctioned or set up shop in some specific way that led to preeclampsia. So some people with high blood pressure outside of pregnancy get lucky. They have to be closely monitored, but there are many of them who won't end up with preeclampsia. And so we watch those people very closely.
Thank you. Are there preventative measures that I can take if I am in those, if I can check some of those boxes that you've mentioned?
Yeah, so I always say first step, I hate to turn to medication first, so I always say first steps first is making sure you're the healthiest version of yourself you can be, right? Some of those things you can't help. If you have been diagnosed with lupus, if you've been diagnosed with diabetes, type 1 diabetes especially, some of those things you can't help. But even though diet and exercise doesn't prevent preeclampsia, setting up your organs to be the healthiest they could be helps mitigate any potential risk that some of these things can have on your body. So that's an aside. With anything in pregnancy, be the healthiest version of yourself. Now, when it comes to people who meet those criteria, either one very high risk factor or two or more moderate risk factors, the recommendation is for a baby aspirin, as we call it, or low dose aspirin, 81 milligrams, usually started at the end of the first trimester, once a day. That you can take through, some people say 36 weeks, some people say delivery. That's probably a nuance that we don't have to get into. But because a lot of this is caused by inflammation, we have found that giving a baby aspirin once a day is one of the few things we've found so far that definitively reduces the chance someone get preeclampsia. Like I said, nothing is 100%. So it's probably somewhere along the realm of 30 to 50%, depending on who you are, but that's obviously certainly better than nothing. So people who meet those criteria, we wait till the pregnancy setup shop, end of that first trimester, before you get to 16 weeks, ideally, we recommend starting a low dose baby aspirin and continuing throughout the pregnancy.
So before 16 weeks and then throughout the pregnancy.
Starting at 12 weeks, ideally before 16 weeks. Do that.
Is there a certain time of day that we should take the baby aspirin? Is there
pop up? No time of day, nothing. Whenever is the best time for you to remember, whether you're a morning person and first thing in the morning you wake up, pop your vitamins, your baby aspirin. So I recommend people taking it when they take their prenatal vitamins, since most people pretty reliably do that. As long as you're getting it in once a day, that's perfect.
Well, these questions are coming fast and furious.
Love it. Talk about this all day, so I'm here for it.
So one of the things, and tell me if this is, let's do some fact from fiction, or yeah, right, fact versus fiction, right? Vitamin B6. Fact or fiction?
Preventing preeclampsia?
Yes. Does it fall in the category as the baby aspirin?
Fiction.
Any research to show that? Fiction?
Okay. I haven't seen anything convincingly with that.
Folic acid.
Fiction. Prevents a lot of other things in pregnancy, abnormalities in how the baby forms and things like that, most importantly, but not for preeclampsia.
High fiber diet.
Fiction. Fiction. Like I said, diet and exercise, if your diet and exercise are poor, because that can affect anything in your body, it could make any bad outcome worse, but fiction.
A low carb diet.
Fiction. See the trend here. No impact on preeclampsia. It's a placenta problem and an inflammation problem. So it's a placenta solution and an inflammation solution.
That was fun. Okay. What about lifestyle changes? Yoga. Practicing yoga? Preventative measures.
Give this a caveat. I'll say fiction. Like I said, anything that reduces stress, inflammation certainly can't hurt. I don't think it would convincingly reduce your risk substantially, but anything that contributes to living a healthy lifestyle, I don't have strong evidence to prove it, but I can't imagine that it would help prevent something from worsening if it's already at its onset.
Last two, amino acid. Any amino acid, any research around amino acid or antioxidant vitamins, lowering the risk of preeclampsia?
Fiction. I've seen some studies, and don't quote me on this. I got to go back and look at this. I think I've seen some studies about vitamin D, but haven't been convincing. There's also been some research about lipid lowering agents, things that lower your cholesterol, like statins, and preventing preeclampsia. We don't have definitive recommendations to tell people to start taking such medications or supplements to reduce the risk of preeclampsia. And I never like to recommend things that are by any stretch of experimental. So I'm hopeful that there are some other things down the pipeline that we'll be able to piece together as ways to reduce the risk. But as it stands now, fiction, unfortunately.
So let's talk a little bit. Oh, I'm sorry. One more question in this category. Is there any current research surrounding preeclampsia and its intersectionality in the forensic pathology community?
Oh, yes. Yes, I want to make sure I understand that question correctly. So I don't know if this was a question in the chat or someone wants
It was a question in the chat.
Okay, yeah, and I don't know if this question is referring to the birthing person who's unfortunately lost their life to preeclampsia, or for example, like after the baby is delivered and research like we do in pathology on the placenta and examining if we can see certain causes. If it's the latter, if it's the former, as in people who have lost their lives to preeclampsia, that I'm not as familiar with. But with regard to the placenta, which is, in theory, the key, right? It is the link, it is the cause, it's the thing we should be examining. There's a lot of research about placental proteins and things that are being released into mom's circulation, about what happens to the blood vessels in the placenta that are predisposing people to preeclampsia. And so I think and that research is really, really important. And there's a ton of research links it to stillbirths, right? And so some of that is like, we're kind of like parsing through a lot of data and a lot of new information, because you can see a protein, you can see an enzyme and still not know how it's working in the pathway, or not know if there's anything we can any medication we can give to prevent it. But there's some work about some of those things that we can use to detect preeclampsia earlier, or to see who's at risk at earlier stages. So I think there's a lot that's going to come up in the way of being better, at least predicting preeclampsia, and then the next step is going to be getting better at preventing it.
So could we spend a little time around that, Dr. Yu, in terms of, you had mentioned earlier that the doc will take my blood pressure to determine if I am developing preeclampsia. Are there other, what's the word? Are there other my brain stopped working.
Warning signs or
yes, thank you.
Yep.
The brain stopped working.
Of course, it happens to me all the time, literally. Yeah, definitely. So, what's interesting is the modern system of prenatal care in terms of the schedule of visits was actually designed to pick up preeclampsia, to stop stillbirth and to pick up preeclampsia. And I always find that very interesting, right? So this schedule of like once a month visits in the first, the second trimester, and then, 2 to 3 weeks, and then a week in the last month before delivery. That was all designed around how the blood pressure changes and how we might be able to detect when people are kind of flying off the scale in terms of preeclampsia risk. So blood pressure is a big one that's checked. Some places will still check your urine for protein every visit. Other places will say, okay, well, let's keep an eye on the blood pressure. If we see something happen there, then we'll check the protein. And those are usually some of the 2 most common triggers that will alert your provider to the risk of preeclampsia. There are also symptoms that we try to educate our patients about to watch out for as a sign of preeclampsia. The tricky thing is some of these symptoms overlap a lot with normal pregnancy, right? So I'll say, okay, if you have profound swelling, that could be a sign of preeclampsia. I almost hate telling people that because I don't want to, like, you're going to get swelling in pregnancy. You're almost definitely going to have swelling in pregnancy. So I don't want everyone to think, okay, I definitely have preeclampsia. But the reason we see swelling related to preeclampsia is, like I said, you're losing protein from those leaky vessels, and protein is what helps keep fluid in your blood vessels. So when you don't have that protein, that fluid spills out into the other tissues in your body. So I try to tell my patients, if you see not just swelling of your legs, which is very common, especially after a long day when you're walking around, it goes away when you put your feet up. But if anyone in your household notices, wow, all of a sudden my rings don't fit well, or all of a sudden my face looks really puffy, those can kind of alert us to, hey, maybe you should either have someone check your blood pressure and or alert it and report it to your provider. Vision changes, preeclampsia can affect the eyes. So, a lot of people get spotters and floaters in their vision, which are, pretty common. So that's not the typical thing, but like missing parts of your vision. That's very dramatic. That shouldn't happen. That could be a sign of preeclampsia. Right belly pain, right upper belly pain. Again, a lot of people get reflux. So you might have mid-abdominal pain. Again, it's also tricky, but if you have right upper quadrant pain, that can be a sign your liver's affected. So I typically tell people, if you get right upper quadrant pain that doesn't go away by itself, things that go away by themselves are very reassuring, or it doesn't go away with Tylenol, which is safe in pregnancy. And it's so severe, especially if it causes nausea and vomiting, new nausea and vomiting that's not your first trimester stuff. That could be a sign of preeclampsia. And then really severe headaches that don't go away with any Tylenol, that are separate from your migraines if you're the type of person who suffers from migraines. So headache, vision changes, right upper quadrant pain, severe swelling are 4 typical symptoms that you hear your provider talk about that people can use for themselves to say, hey, after 20 weeks, could this be a sign of preeclampsia? Do I need further evaluation?
Red flags.
Red flags, exactly.
So not fast forward, but I'm diagnosed with preeclampsia. What does that mean for me? I'm 22 weeks and I'm diagnosed with preeclampsia. What does that mean?
Yeah. Preeclampsia becomes a balance of any pregnancy is really the mother, the person carrying the pregnancy, essentially putting their body on the line, putting their life on the line to develop a child and to birth a child. And many people are happy to do that, right? But at some point when certain conditions come up, our question becomes, when do we strike the balance of when things are not so severe that the birthing person's health is at risk, that we can allow the fetus or the baby to develop more? And when have we gotten to the point where it's like, this baby will do just fine on the outside, and or the risk to your life is really severe and we don't want to take any challenges. So that's the question that your provider is asking themselves when they're making recommendations about delivery timing. If you get preeclampsia at 20 weeks, I will say the earlier you get it, it tends to be more severe, and 22 weeks is pretty early. But as a general rule of thumb, if you have very uncomplicated preeclampsia or hypertensive disorder of pregnancy, once you get to full term, 37 weeks, generally, if there's nothing else going on, that's when your provider may let you get that far. If it becomes more severe, then you may deliver earlier, preterm, even as early as 34 weeks, sometimes sooner. As I mentioned, preeclampsia can affect mom's health, right? So if we're going to follow you much more closely. If you develop preeclampsia, you may see your doctor more frequently for blood pressure checks. You may have more frequent ultrasounds. You may have more frequent blood work. Because if we start to see things are getting to a point where your kidney is failing or your liver looks like it is at risk of bursting, we may call it quits earlier and say, we really need to talk about delivery. So there's a couple of things we do. We watch mom very, very closely. If it's very severe, it might even be inpatient hospitalization. If it's mild, they could be managed outside with very close follow-up. We also watch baby very closely. So like I said, preeclampsia can affect the placenta, which can affect the baby. So we watch the baby regularly to see if there's any sign that the baby's growth is not what it should be. We're seeing growth restriction. To see if the fluid around the baby is compromised, that's a sign of when the placenta is not working as well. So it becomes a plan of really close follow-up for mom and baby, trying to see that there are no severe enough complications that we need to kind of, pull the trigger on delivery, and then determine what's the best timing to monitor somebody.
So it's not a foregone conclusion that if I'm 22, 23 weeks, that I will have to immediately deliver.
Correct. That's a great way to phrase it. A diagnosis of preeclampsia does not mean you need to deliver. And I think I saw pop up in the chat, maybe we'll come to that question, and it does not mean you need a C-section. There are many other things that surround preeclampsia that could impact the recommendation to, for safety reasons, do a C-section or deliver at a certain gestational age. But I don't want anybody to be scared that if, unfortunately, you're one of those people who develops preeclampsia, doesn't mean you have to deliver right then and there, and it does not mean you need a C-section, even if those things are unfortunately more likely for many other reasons.
Not that you're giving medical advice, but just curious, why would it almost necessitate a C-section? Because you don't want the mother to go through that.
Yeah, it's usually, so there's mother reasons and there's baby reasons. The most common mother reason is, sometimes preeclampsia comes up without much warning, severe preeclampsia without much warning. So let's say someone comes to me, you have severe preeclampsia, and I'm looking at your blood work and I see, wow, your kidney has really been affected. Came up out of nowhere. And a week ago, your kidney was normal. Or in 2 days, your liver tests are off the charts. To deliver someone vaginally takes time, right? Especially if you're not in labor on your own. We have to help get your body get into labor. We have to wait for you to dilate. We have to wait for you to push, and which could be a varying time depending on if it's your first baby or not. So we say, listen, we don't have the luxury of time with your life on the line to try to facilitate a vaginal delivery, even if that's what we would like for mom and baby. But if we are going to prioritize your health and keep things safe for you and this baby, then I think a C-section might be the answer. Or preeclampsia can get so severe that it affects the baby's growth and affects the baby's heart rate or response to contractions. Very small babies or weak placentas sometimes don't tolerate contractions as well. And we may see a lot of drops in the heart rate. So like I said, it's, preeclampsia alone doesn't mean the baby's going to need a C-section, but babies of mom with preeclampsia sometimes, for reasons that the preeclampsia has affected them, have trouble tolerating the contractions that are a necessary part of labor. And we might say we can give it a try, or we're worried about even giving it a try and how it may affect your baby, and we recommend the C-section.
Good.
And
Thank
I think
you.
the thing I'll also just chime in there, I think, medicine has shifted a lot to where a lot of this is a conversation, right? I think in the heyday, your doctor tells you something, you go with it. You're like, okay, I trust that you have my best interest at heart. I'm going with it. Nowadays, for many reasons that we've seen, like people want to know more information. So, sometimes people will come to me and ask me like, oh, my doctor told me this, does this make sense? And I'm like, listen, should not entirely trust someone who has not seen your care, your whole history to give you advice. But what I would encourage you to do is sometimes we as doctors take for granted the things people want to know and understand. So if you just ask, like, what is it about my situation that is making you recommend X or Y? And with the luxury of time, which most of the time there is, press your provider to help you come to terms with understanding. You still may not make the same decision, right? And at the end of the day, the decision is yours as to what's happening, but you'd be surprised how much more frequently their priorities and your priorities are more aligned than you realize. And it's just a matter of everybody kind of being on the same page and them understanding what's a priority to you, right? So,
Right. I think that's why it's so important to have the training that different groups do that help you learn how to have that conversation with your provider is so critical, in my opinion, just as a person that plays a doctor on Zoom.
Agreed.
This is a good question, and that's where what triggers a decision to deliver or induce. I think we've answered that one. Well, I guess no, maybe we didn't answer this one thoroughly, because we talked a little bit about your 22 weeks, 23 weeks, and you do start to develop preeclampsia. They see the protein in your urine. Your blood pressure's ticking, ticking up. When do they say, okay, we do have to take this baby at 23 weeks, or we have to take this baby at 24 weeks, or we're going to give mom the, a few more days and then do all that stuff that they do to make the little kidneys grow, and not kidneys, but lungs grow, do fungal. But at what point then do they say we've got to induce?
And I think I saw part of this question, maybe
Yes.
you're looking at the same question. You're right. So there are things that go into diagnosing, right? And I saw someone on the chat mention, 2 blood pressures at least 4 hours apart that are over 140, over 90. is gestational hypertension. Like that alone will have you probably needing to deliver early at term, a diagnosis of gestational hypertension or hypertension in pregnancy. You add other criteria that indicate to your provider that one of your organs is compromised, and that causes diagnosis of preeclampsia. So the most common one is protein. That's an indication your kidney is compromised. So that's why a certain amount of protein makes the diagnosis. Or your blood system is compromised. Your platelets, which help with blood clotting, can be really low. Your creatinine or your kidney function above a certain threshold, you say above 1.1, the specifics probably aren't as important here. Your liver function, that's twice the upper limit of normal. Like I said, or a headache or upper abdominal pain that really doesn't go away. So all those things will make the diagnosis. Now, when you ask what is it that triggers delivery, probably think of it in a way that there's only so much modern medicine can do to keep up with what your body's telling us, right? So you have high blood pressure, I'm going to give medications to bring the blood pressure down. At a certain point, I may give you blood pressure medication, and now we've gone up and up and up and maxed out the dose. Or I've given you a second blood pressure medication and I can't go up on that anymore. Like at some point, we're fighting a losing battle, and it's going to result in something more severe, a seizure, a stroke. So I can't give very specific criteria because it actually is, for lack of a better word of art, it takes a little bit of kind of like judgment of how sick you think the person is to decide what, like some people may stop at one blood pressure medication because the fact that you were on nothing earlier today and now I have you on the max dose of that medication with a severe headache at the end of today, your life is in danger and I'm very concerned, right? Whereas somebody, I might let them go on 2 medication. So it's a little bit of judging the clinical situation, but, and there's certain things we can't treat, right? I can watch your kidney function, but if I keep watching it and your kidney function has not only gone above normal, but it's getting to the point where it's 2, 3, 4 times the upper limit of normal function, and you're really in kidney failure essentially, or injury, severe injury, and I'm afraid it might not recover. Or your liver function tests are so high that I'm afraid if I let it keep going, your liver might rupture. So there's not a lot of hard cutoffs, but it's more so we've exhausted ways of treating. We can treat blood pressure, we can't treat your kidney or your liver. And it just gets better when we deliver you. But exhausting the amount we can manage what's happening to your body before we're really concerned something severe might happen is when we decide to induce or recommend a C-section.
That makes sense. I hope we answered that for you. And this is a good question. Prior delivery, or prior pregnancy, developed preeclampsia. She developed severe preeclampsia at 28 weeks, carried the baby to 34 weeks. Now on the fence because of potential preeclampsia with, I guess, the subsequent child. What are the odds of getting it again or not getting it? What is if I've had preeclampsia with a first child, what's the risk of developing it with a subsequent child?
It's pretty high, unfortunately, and this is a number I really should know off the top of my head, but I think it's as high as it's somewhere in the 30 to 60% range. I know it's a wide range, but in medicine that's very high, right? Once you get above a third chance, you're banking on that likely to happen. I think it's even high, and especially if it happened early. The earlier it happens, the more likely it is to happen again, and the more severe it could be, and the earlier it can present. So unfortunately, and I've seen many people who've had preeclampsia and unfortunately had to deliver a baby preterm and have gone through all that entails, who have had a subsequent pregnancy where they didn't develop preeclampsia. They're on a baby aspirin, we're watching very closely, but many of them commonly do. So, you have to weigh kind of, carrying a pregnancy is really important to a lot of people, and understandably so, right? But there's a lot of conversations that can be had about, okay, what are the things to monitor and mitigate the risk? Aspirin, 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 that's going to be the number one. Absolutely be on that aspirin. But some people even consider saying, hey, this is very traumatic, and if it's within my resources or within my values, like to consider surrogacy or someone else care. I think that's something that even I forget to bring up as often as I should, like to give people their full range of options as to what's the best way to expand my family in a way that I'm comfortable with how my
Mhm.
health is on the line. But there are some, I've seen many successful pregnancies after an early diagnosis of preeclampsia, and whether it's the aspirin that's doing the majority of it or what else is involved, it's certainly possible.
Thank you. So we've carried our baby with the diagnosis. We are delivering our baby because we talked about delivering, whether the decision when to deliver. So I'm going home. Is it done? Don't have to worry about this anymore. It's like call the midwives. It's all a happy ending, or is there
Yeah,
concern?
I know that's what we're getting at, and that is my huge area of interest and area of research is postpartum preeclampsia. I think that's something that even in the medical field, we underestimated how big of a burden that is. Because you guys have heard me said time and time again that the placenta is the problem. The placenta is what causes it. It's what leads to all the symptoms we see. So reasonably, we used to think, well, if the placenta is out, then it's cured. It's like, well, yes, but no, right? Because it's not just the placenta, but it's all these factors and proteins that the placenta has released into your blood supply. And I'm sure there are many people on this call who've had a baby and who know that when you deliver that baby, you don't all of a sudden go, great, back to normal. My body is just what it was before I was pregnant,
Right.
right? And the same way you feel is the way your body's acting. It takes time for your body to clear all the proteins and all the changes that your body has gone through during pregnancy. And I think, I happen to believe there's still a lot of research going on in the field, but that's probably the reason that postpartum preeclampsia is a thing, right? So the risk of preeclampsia gets, you know, more as you get closer to delivery. It's hard to know how high it is in the postpartum period compared to like right before delivery. It's probably a little bit lower, but still quite high because you're waiting for all that to kind of flush out of your system. But at least probably we say, the first 1 to 2 weeks is probably the highest risk time. We think it can happen up to 6 weeks. After that, we think your body is closer to its pre-pregnancy state, but unclear. Like I said, it's a very active area of research. But I always tell my patients, I say, listen, we're having a lot of these conversations about the monitoring that you need to do after you go home. And when you go home, in addition to us checking in on how your mood is, in addition to us making sure you feel like you're healing below appropriately physically, I always counsel people, especially if they were already at risk for preeclampsia, to watch out for those signs and symptoms we talk about after delivery. So when you go home, if you have it's tough, right? Who doesn't have a headache from sleep deprivation with a newborn, right? But if you have a really severe headache, doesn't go away with Tylenol or Motrin that you can take after delivery, those kind of warning red flags, don't be afraid to call your provider, because the sad reality is that 70% of the deaths that happen with high blood pressure related to pregnancy or preeclampsia happen after delivery. Why? Because we unfortunately didn't realize that that was such a high risk period. So while we're spending all our time with, microscopes, examining people and monitoring people before they deliver, they go home and, I've seen in the way our medical system works, there's not a great avenue to continue that monitoring and communication with your provider. So more reason why, as we change that, people should recognize, like have a high index of suspicion. If things don't feel right, you feel like you have those symptoms, if you feel like if you need a cuff at home, or if you don't have a cuff at home, stop by your local CVS. If you're having those symptoms, check your blood pressure. And just be aware that it can happen probably up to 6 weeks out, certainly up to 1 to 2 weeks out.
So that was on my list of one of my questions, Dr. Yukashi, is what are some of the things we should have at home? Are there things that we should have at home? So one was, do we continue the baby aspirin after the baby's born to mitigate the risk of developing postpartum preeclampsia, or no?
The recommendation is no, but
Okay.
not because it doesn't work, but because nobody has studied it. So like I say, I can have all kinds of ideas about what I think works, but I'm very hesitant to recommend things that haven't been proven, because everything's harmless until you prove that it had some unsuspecting harm, right? So there's no formal recommendation to continue the aspirin after delivery. In fact, for people who have preeclampsia, there is evidence for what we call diuretic. Some people may have heard of Lasix, furosemide. Essentially, it helps draw extra fluid out of your system and help you pee it all out. So people who get preeclampsia in pregnancy, there's now pretty good evidence that giving like a 5-day course of oral diuretics or medications that help you pee can help your blood pressure get back to normal, your body get back to normal sooner. It's not standard of care yet. It hasn't made it into our official guidelines, so not every hospital prescribes it. But there are some medications that are coming down the line, down the pipeline. So in terms of things that are recommended that I think are very reasonable that everyone should have and do, I don't think it hurts for anybody to have a blood pressure cuff at home. At the very least, if you have those red flag symptoms, you can check your blood pressure. And it's a little tricky, right? Not every blood pressure is calibrated so that it's accurate with regards to what we see in the office. And not everybody is instructed properly on how to take a blood pressure, you know, sitting, feet flat on the ground, legs uncrossed, don't have any coffee or run around beforehand, sit for 5 minutes, arm at heart level, and take your blood pressure, right? So it doesn't hurt for anyone to have a blood pressure cuff. And so that's my main recommendation. High index of suspicion of the red flags and a blood pressure cuff to check your blood pressure, because you can always call your provider and they say, I'm not sure, let's come in and check it out. I'll go from there. I'm hoping we're going towards a world where we have more digital and remote monitoring, so people aren't bouncing back and forth between the hospital, and we can help manage these things and bring people in at the right time. We haven't quite gotten there yet as a field, but that's all part of the work and research that's being done to help that.
Well, you know, you make a good point, because we always talk about your postpartum village. And so maybe that's one of the assignments that we give our postpartum villagers, is learning how to take our blood pressure. So get the cuff before you have the baby, and then have them learn how to use it. And how frequently are we taking our blood pressure when we come home?
I usually tell people, you know, it's tough because if you're not in the highest risk category, once a day may seem like a lot, and it probably is a little bit overkill. I don't think once a day hurts. I think most important is, so once a day would help catch if it's, you know, going up before it gets so severe that you have symptoms. So if you were the most cautious, I would say once a day is probably reasonable. Doesn't matter what time of the day. Some people do it first thing when they wake up. Some people do it after a busy day because you know your blood pressure is probably going to be the highest it'll get then. So if something's happening, you'll catch it then. Any time of the day that you can remember, you know, the hours blend together when you have a newborn is probably sufficient, right? It's better than nothing. But most importantly, I tell people if they have some of those symptoms, very severe headache, very severe right upper quadrant pain, really odd vision changes. And the swelling is again tricky, right? Because a lot of people think I'm delivered, my swelling should go down, right? Actually, all the fluid that you build up during pregnancy, your body starts to move it around and send it back into your blood vessels 3 to 6 days after you deliver. So a lot of people will recognize that in the first week after they deliver, they go, oh, my swelling got a lot worse before it got better. And that can be normal. But, you know, again, if you have that swelling or you see it in your hands, you see it in your face, check your blood pressure. The checking your blood pressure is kind of a backstop on if I'm having any of those symptoms, let me see if they might be normal, if they're associated with high blood pressure issues that I need to learn someone about.
Well, that's a good one. Oh my gosh, we've got 12 minutes, but I want us to spend a little more time on the symptoms, doctor, if we could. Remind us again, what are indicators that we should raise a red flag?
Yes. So severe headache, especially one that doesn't go away on its own or with Tylenol. Headache, severe, I'm sorry, of course I've got sirens in the background. I don't know if you guys can hear that, but they're alerting to the warning signs too. Severe headache, severe right-sided upper quadrant pain. So it's usually like under your ribs. Again, that doesn't go away on its own or with Tylenol, especially if it's associated with nausea and vomiting. Okay, so we've got the severe headache, we've got the severe right upper quadrant pain, we've got vision changes. The most typical one is like all of a sudden part of your vision goes missing. So some part of your vision will feel that either eye just goes dark or goes missing. People often get evaluated for floaters, but floaters can be pretty common. So if you have floaters and they go away, you're probably fine. But visual changes is the third one. And the last one is rapid swelling or severe change in your swelling.
And that is prenatally and postnatally, correct?
Exactly. And that's probably one of the trickiest ones to tease out from normal pre-pregnancy or postpartum swelling. So I try to couch that one with a little bit of a caveat, but that certainly could be a sign.
Thank you. Let's see if we missed any questions. I hope everyone else finds it as incredibly interesting as I do. And when we think about how often we hear someone say, I developed, have a really good friend that developed preeclampsia almost overnight. Her little guy was almost 23 weeks. And it was profoundly impactful on her pregnancy. They ended up having to deliver him right before he was 24 weeks. He survived. He's my godson. But we've had a lot of challenges since. So just the more we know. Any other questions that we have? Let's see.
I just saw one part of the question I previously answered that I think would be important to touch on about, being diagnosed with preeclampsia early and the risk for the next pregnancy. And the last question the person asked was, would a consult help with that decision? Absolutely. I mean, I recognize I am not afraid of preconception, and we call it consultations or consultations before you deliver for anyone. I think it can help shed light on any of your health history. But there's so much we don't know about preeclampsia and so much individual variability that I wholeheartedly support and recommend and agree that it probably would help to see a provider who could thoroughly review your history and the course of what happened and counsel you on how likely they think it is. And that might help you decide what the decision may be.
Another question is, why are Black women at higher risk for developing preeclampsia than other groups?
It's a number of reasons. The majority of the ones that overlap with the other risk factors I won't touch on. But I think the thing I try to communicate with people is that it's not biological, right? Because, the only part of our race that's genetic is how much melanin you produce, right? So like, there's nothing about the gene that says like you're going to get more preeclampsia. We don't have the answer because it's hard to tease that out with research. But if I had to guess, I would guess it has to do with kind of systemic pressures, stressors, all which translate to stress, which we know translates biologically, cortisol and how that affects your blood pressure at baseline. A lot of how societal stress and pressures impacts our baseline health and inflammatory status and things like that, I imagine contribute to it. Who knows what of it has to go with disparities in like kind of attention to symptoms or diagnosis. That's unclear, and I don't want to speculate too much, but if I had to get down to like kind of a biological cause, my guess would that it has to be with the stressors and the impact of social stress on our bodies.
And there is some
racism through the life course. Exactly. Thank you. Calling it out. Racism through the life course has an impact on the way stress affects our bodies.
Because isn't there some indication for like first generation Black Americans versus multi-generation Black Americans and their experiences? Isn't there someone that's taking a look at that, or has
there's a lot of literature on that, I know, in terms of maternal mortality in general, right? That Black people, I mean, it's Black in the race term, Black people who have migrated don't have the same mortality rate. It's lower compared to people who have lived here. So if you're in a generation that has lived here, your mortality rate is higher compared to foreign born. And that just demonstrates how racism impacts the life course and, kind of goes through the generations and has a compounding effect.
Before we lose our
healthcare is a stressor to agree.
Right.
And all the stressors that impact us.
Okay, getting back on task.
Okay. I can get on.
No, I mean,
yes,
it's wonderful discussion, and it does bear paying homage to. But I don't want us to lose the opportunity to just take a peek at some of the emerging data that is looking at the preeclampsia. We talked about it doesn't necessarily go away when you leave the hospital. There's also some emerging science that says if you develop preeclampsia during your prenatal period, there is some impact on there could be impact on your long-term health. Can we
yes.
talk a little bit about that?
Thank you. Yes. Oh, I can't believe I almost forgot that one. Thank you, Marie. Um, you know, I always describe how when you're pregnant, your body goes through a lot of changes, and we kind of think of it as getting back to your pre-pregnancy baseline. But as we all know, your body's almost forever changed by pregnancy, right? And that includes from the complications that you suffer through. Some of it is probably some degree of, you know, pregnancy pushes your body to the limit, so it shows what conditions may come up when your body's pushed to the limit. And what I mean that to say is, when you have all kinds of things that are testing your ability to, respond to insulin, you get gestational diabetes. That tells you what lifelong testing of your ability to respond to insulin will produce. So people with gestational diabetes are at higher risk of type 2 diabetes later in life. It's like showing the stress test on your body. So similarly with preeclampsia, whether it's just showing what your body demonstrates when it responds to stress, that can happen in pregnancy, it will happen with the eventual wear and tear bodies throughout our life. Or whether it's how some of that inflammation has, almost irreparably impacted our blood vessels that could lead to high blood pressure. Unclear, we're still trying to sort that out, but the fact of the matter remains, pay attention to that warning sign your body gives you, right? So if you get preeclampsia, high blood pressure related to pregnancy, you are at higher risk for getting high blood pressure further down the line, for getting cardiovascular disease, heart disease, things like that down the line. So it's a word of caution to, make sure we get on top of living a healthy lifestyle, even more so than we had originally planned to, because all those things will help us prevent our body being subject to those consequences. But yeah, unfortunately, that does result in long-term, we say, cardiovascular or heart disease risk and high blood pressure risk. So we should be following up with a primary care provider or doctor regularly each year to check on our health and make sure it's optimized.
Thank you. Thank you. So
thank you for asking that. Very important part of the discussion.
thank you. I wanted us to slip that in because I've read recently that a lot of times, and it increases your risk fairly meaningfully. Should we do key takeaway, Doctor? Key takeaways in our last 3 minutes.
Sure. Okay. Preeclampsia can happen to everybody. It's no fault of anybody's own, which is a point of awareness, but not fear. Hopefully we're now equipped with the signs to look out for with preeclampsia after 20 weeks. The ways to prevent it, if we either ask our provider or look up the risk factors and see that we qualify for a baby aspirin, which is the one tool we have to reduce the risk. A diagnosis of preeclampsia does not mean you have to deliver then and there. It does not mean you have to have a C-section, but it is a careful discussion of monitoring your health and your baby's health in a decision with your provider to make sure we're keeping both safe, because many people with preeclampsia will end up having to deliver early. And so our goal is to support mom and baby to a time when that's safe and reasonable to continue through. Preeclampsia can happen throughout pregnancy. It gets more common as you get further along. It can happen slowly. It can happen immediately. It can happen postpartum, even up to 2 to 6 weeks postpartum. So that care that we're taking to pay attention to our symptoms during pregnancy should continue at least through 6 weeks after delivery. And if anything, the least we can have is a blood pressure cuff. And at the very least, we can monitor and see if we are at risk and if it's happening to us, and kind of advocate for seeing our provider. Did I cover all the big ones? I think I covered all the hard ones.
Yeah, I think you covered them. Everybody in the audience, everybody, did she cover them? Are you guys leaving armed with knowledge? And I will do a not a shameless plug. I'm going to do a teeny tiny commercial for our next workshop that's starting in 1 minute. Because I think where my co-conspirator who's in here just dropping pearls, Leslie Farrington, Dr. Leslie Farrington, one of the points that she does make is who your provider is can often make a difference in the outcomes with this. I'll do a teeny tiny plug for one of my dear friends who's a brilliant perinatologist. Maybe I should name her, maybe I shouldn't. I think Dr. Yukachi knows who she is.
Oh yeah.
My daughter checked all the boxes. She was carrying multiples. She was over a certain age. She was all the things, and she did not develop preeclampsia. But she had a phenomenal doc. And so I'm going to lead up to our next workshop, which is Womb Chronicles, an unfiltered take on birth professionals, because I think that who your provider is, if it's someone who listens and cares and is really into the science, the way Dr. Yukachi has shown that she is, it makes a difference. So stay on. Well, you can't stay on. Log on the next Zoom webinar and join us where we talk about where the provider makes a difference. Thank you, Dr. Yukachi, so much. It was lovely chatting with you. Thank you all for joining us. If you're joining us on the next webinar, we'll be on in 30 seconds. Have a good evening,
On the next
everyone.
one.
Thank
So
you.
good to see you, Marie.